can you hear me? I'm unmuting you. Yes.
Thank you very much. Is the voice clear this time?
Yeah, I can hear you. I can hear
Excellent.
you.
Thank you.
Just 1 second. I think there is a confusion regarding uh, selection of candidates. Just bear with me.
Sure. Please take your time.
Sorry for that. Over to you, Khalid. Last time we saw a very um, unique session, and the cases were absolutely mind-boggling. This time they will be more, to be type of stuff. This is what the plan, I believe, is.
Sure. Yeah,
But
yeah,
they will be GI, isn't it?
it's all GI, yes. I
Yeah.
mean, people want other things, and it's always there's more cases, but I think there is quite a variety. I think the challenge always in the exam, the 2B, is scrolling through GI cases in very limited time and how to fill the gaps. So there's a lot of technique involved in this. It's not only about the diagnosis, but we'll see some interesting cases too, quite interesting, nice, rare ones also, which will also inform the candidates. But on the other side of it, how you're going to scroll. So hopefully we can give control and the candidate can scroll, and then we'll walk you through the different cases. I can chat a little bit about the 2B exam technique for people who are dialing in. When you go into the viva, you get different sides of examiners. So somebody will be quiet, somebody might be a little bit intimidating, trying to ask more questions. So this is very important to practice what different styles. Is the voice problems again? Is my voice clear
No,
or not?
perfect.
Yes, thank you.
Absolutely perfect.
So that's
So
important.
just 1 second before you begin.
Sure.
The plan is for the audience that we have got 4 candidates. And Khalil, if you want to talk about the exam and things like that, feel free. If you want to go beyond 2 hours, feel free. This is an opportunity that people don't miss. So if you want to talk generally in terms of exam, give them advice, absolutely fine. Number one. Number two, each candidate will get 30 minutes Viva. It's going to be a teaching Viva, means you will be given feedback after each case. Khalil, that's the plan, correct?
Yes, and then we'll teach through the case,
Yeah.
talk through the case.
So over to you then. I'm going to switch off my video and audio, but I'm with you.
Excellent, thank you. I might actually save the time and trying to go through cases. There's quite a few cases, and then every time we coach the case, we'll talk a little bit also about the technique. I'm just going to move my screen so I can start loading. And if we got candidate one, can you hear me?
Yes, sir. I can, but a bit low.
All right. So I'm going to share now a case, and if you can request control by any chance.
Yes, sir. I will just request. Sir, I requested.
Okay, give me 2 seconds. This message appeared and then disappeared. Can you request it again for me? Sorry.
Sir, I request again? Yes,
Yeah.
sir. I requested again, sir.
Yes, now I can see it. So excellent. So can you now scroll, try and move? Yes. So what I would advise, you see this ball on the side, just scroll up and down, that's the easiest. And if you need any reference windows or any recon, just let me know and I will do it for you. And that's what was going to happen in the exam. I'll introduce myself. My name is Khalil Gendi. I'm one of the radiologists. You are now in the 2B exam. This is a patient who coming with acute abdominal pain. The last 2 days, been vomiting and being sick. And we have done a CT abdomen and pelvis for them.
Yes, sir. CT post-contrast studies of an adult patient, in which I can see small bowel dilatation. I was able to spot some surgical clips down in the pelvis. or some calcification, most probably. Because there is artifacts, most probably this area.
Okay. What does that
And so
mean?
is there any history of any surgery and like,
Not abdominal surgery, no.
sir? So there is small bowel dilatation.
Okay.
Apart from that, the large bowel is collapsed,
Okay.
and I would like to see the ileocecal junction. That looks okay. The appendix is okay,
That's fine.
but I want to see the cause of obstruction, sir. Sir, is there? This is a. I can feel something an enhancing structure within the bowel in the right iliac fossa region here in this area.
Okay.
Sir, I would like to view the coronal sections if possible for this case,
Sure.
although
Give me
there is
two
no free
seconds.
fluid and no free air. Sorry, sir.
No, okay. I'm gonna give me in control 2 seconds. Don't move it yet. I need to get the coronal and then give it 2 seconds
Yes,
on
sir.
you. No, you can scroll now.
Yes, sir. Okay. I have to request again, maybe.
No, it should work.
Yes, sir.
Okay.
I
Okay, go.
requested again. Take a time, maybe, sir. It's not scrolling with me.
You can use the mouse or you can, yes, that's it. Go for it.
Okay, sir. I was able to spot this area that is giving a target sign appearance in
Okay.
the right side of the abdomen. That appears to be an area of bowel, lumen, bowel within a bowel, like interception.
Are you sure?
It's
It's
scrolling very
obviously
badly.
is old patient, yeah? You got hip replacement and things. But okay, what other differentials? So you're saying is intersusception, okay? Um, there's no free air. What else you look for? And what's your differential?
Sir, although this doesn't look like the point of transition for the small bowel dilatation.
Okay, are you sure?
Um,
I'm being kind today, but yes, sometimes I'm not gonna tell you that. And say, okay, where is the transition zone then? So we can.
so whole of the small bowel is dilated, like it is dilated till the ileocecal junction. That's for sure.
Are you
Like
sure?
this is the ileocecal junctions of this area.
Okay.
That's a bit collapsed, and then this is the collapsed part of the
Okay.
distal ileum. This
So
one,
that's
and
collapsed
this is
bowel.
the area. Yeah, so it is leading to this area again.
So that's the transition
So yeah,
zone.
that's the
Okay.
point of transition. So and there is a within within this mass like area is actually
Okay.
like there is the point of the lead point for this interception that could be a
Okay.
mass, that could be a lipoma, um, that
Okay.
could be a metastatic lesion or CA, and
Okay. So we're talking about
yes,
intersusception, and you said fat. I mean, it doesn't have fat density, doesn't it? But let's look at what could be else differential. And can you see anything else in the abdomen other than the bowel obstruction that could help
sir,
you
I will
to?
go through my all the areas. The liver appears grossly okay.
Okay.
Like there is no filling mass, or the hilum is okay, the
Okay.
spleen is okay, the kidneys grossly appears okay, and I think I'm going to back.
Sure.
All right, kidney is a bit malrotated, degenerative changes.
What is
Uh,
happening to the gallbladder?
oh yeah, exactly. Sorry.
Okay. What do you think?
Sorry, it is irregular and the wall is thickened, and there is some sort of free air here in the hilum.
Good.
Yeah, this area, sir. And it is very irregular, collapsed, thickened walled, and so it could be a gallstone ileus. No, but I didn't see any calcific density, but because of the collapsed irregular wall and also the free air,
Yeah.
I am suspecting that there is some element of gallbladder perforation.
Okay. Does
So I would
does the transition zone looks like a
yeah, it does look like, but it is not very much definite as calcific, but it does have this concentric ring-like appearance.
okay?
So as the gallstones can have, like the stones can have different density, especially the gallstones, they are not very much good, nicely visible on the CTs.
So, okay, the surgeon on the phone. What are you gonna tell them? And what's your next step?
So kindly, just 1 sec, 30 seconds, sir. My daughter came inside. Just, Sana, go outside. Go, go, go. So sorry, sir. Sorry, extremely sorry, sir.
It's
Yes,
okay.
sir.
What's your conclusion?
So, sir, to summarize, there is irregularity in the gallbladder wall with associated small foci of free air, followed by a concentric ring-like area that is seen in the right side of the abdomen, causing secondary dilatation of the small bowel. So the
Okay.
features are most likely suggestive of gallstone ileus. So I will immediately recommend this patient to inform the findings to the referring physician and ask for the surgical consultation of this patient.
Okay. So likely this is acute bowel obstruction. What I want you to show you here,
Yes, sir. Yeah,
and I'll give you
I
some
missed it.
feedback now. So yeah, so very important to have a systematic approach, how you're scrolling and fill in the gaps while you're scrolling, looking from up to down. You spot already the pathology, which is dilated small bowel, keeping with bowel obstruction. Then you look for the transition zone. You want to exclude free air, always ask for lung window because there will be
Yes,
subtle pockets. So you mentioned that the examiner want to move on, so we tell you there's no free air, or if there's free air, he will put the lung window and then you spot the free air. So that's an exam trick. Now that will save you a little bit of time. Looking for transition zone, you spotted it, but somehow you're starting doubting yourself back and forward. So you have to put your foot down and start moving. If you've had a little bit of doubts, you have to think, okay, what could be else? What other differential when I'm trying to help you? So going back on your answer usually doesn't help. Your first instinct is right. You've got collapsed bowel is leading to this. We can put it on the coronal to confirm, and that could be intussusception. That's one thing. One other things you look in the when you see dilated bowels, what I want to hear is a bowel ischemia, there is any perforation. You tell there is new free air, the thing is bowel ischemia. So you look at the bowel is all enhancing, you look for portovenous gas. And once you go to the portovenous gas, we'll look and review, then you notice, oh, hold on, there's a new mobilia here. And that could be, and you can see this is the site of the cholecystodunal fistula. Very clear here. You see that? The air
yes, sir.
going. So that's a cholecystodunal fistula, and you've got to interpret that the differential could be gallstone, and this is classic gallstone illness. It's very common in the exam. It will come. It's straightforward. Good. So if I'm going to score you on this one, I'm going to score you 6, which is still safe. You could score more
Yes.
easily by just being a bit more systematic and being more confident. The
Yes, sir.
differential could be interception, as you mentioned, but the interception, if you look at on different plane, will not look the same.
Yes,
So if
exactly,
you
sir.
look at the target sign in one here, and the other sign will not be that way. There is a case of interception later, but I don't want to spoil it for the time being. Okay. Any question about this case from you? If not, we'll just have to move on. Just focus more again. Also, you presented very well your confidence, so I wouldn't worry too much. It's just getting more practice is very important.
Sir, I was getting distracted by the surgical clips in the pelvis. So were those calcifications or what?
I don't think you need to go the way. The bowels collapse. I think this might be just some calcification. I'm not sure. I think this is the vessels because that's arterial enhancement. So that's the uterus, probably
Oh,
an
yeah, okay.
ovarian
These are
vessel. So
vessels, it's
I wouldn't.
calcified vessels.
Yes, exactly. So I wouldn't worry too. Don't get distracted. There's a lot of
Yes, sir.
side things, but that's not the main action. And the exam is about interpretation and safety. This is very two
Okay.
important things. There's large, small bowels. The rest is, I don't want you to comment on this and that because there's a lot of distractions. Can happen also in certain cases. Okay, let's go to the
Also,
next one.
yes, sir.
This is a patient coming with acute abdominal pain, young patient in their 30s. And come to the ENE. Acute abdominal pain, feeling unwell, feeling a bit septic, has been for the last 5 days. Can you still scroll? I think you can. Okay, it takes time to load, should be smoothly.
Sir, I am able to scroll, but it
It is
the
still
scrolling
loading.
from my is not very good, sir. Okay, sir. Sir, I've been presented with the CT scan
So
axis
just to say,
section.
just to say, in the exam will be cranky as this too. I don't know, they're using a new system rather than Teams within the Royal College, but it will be cranky. So get you, this is part of the exam experience.
Okay,
So
sir.
go ahead.
Thank you.
That will happen.
Sir, yeah, sir. Axial CT sections post contrast images presented in which sorry, I didn't hear the history, sir. The patient with
Just been septic for 5 days. Has been ongoing abdominal pain. Last 24 hours been septic, feverish.
sir, abdominal pain, and I've been presented with the CT axial section post contrast. So I'll try to scroll to the images. What I see is some gas and some gas foci in the wall of the bowel of the in the wall of the small bowel with associated mural thickening and some diverticula as well. Most probably this is actually in the descending colon adjacent to the spleen. There is a circumferential mural thickening. Just scrolling very slow.
Take a minute and look at the rest of the abdomen first before
Yes,
you
sir.
come into any conclusion. So we'll just quickly scrolling through. I think what you need to scroll easier is to hold this button and just scroll it down. It will work better for you.
Sir, I'm doing the same. Actually, maybe
So I try to help you a little. So are you scrolling through the mouse or are you dragging that round
I'm
button?
trying both ways, but now I'm doing from the keyboard.
I want you to drag this circle here. Do you see that circle on the side?
Yes, sir. Yes, sir.
Yeah, try and hold it.
Okay.
Yeah, that will be quicker. And go down. Go down, go down. It's fine. That's much quicker, yeah.
Yes, sir. Okay. The pathology is here, sir.
Okay.
There is an irregular loculated collection that is seen in the right side of the right iliac fossa region with the central necrosis as well as like central collection with free air fluid level. Apart from that, I can see an enhancing appendix within this mass, this area region. I will like to show you that.
Please
This
do.
is a blind tubular structure.
Okay.
That is most probably an appendix.
Where's
Sir,
the
this
heading?
one, sir, this one, sir. This
Okay.
one, sir, this one. So, there is amalgamated bowel loops, there is fat stranding, there is a collection, abscess formation with free air. Like this is actually a phlegmon formation in the right side of the abdomen. So, with the for my first and foremost diagnosis in this patient will be complicated perforated appendix with abscess formation.
Okay.
And however, I would like to confirm it with the clinical history and the clinical data like WBC count, and if there is any ultrasound available, I would like to see that and refer it to the inform the findings to the referring physician, and again ask for the surgical consultation. Especially if it is drainable, then I would like to first consult the IR teams. If this abscess is drainable, then they might drain it first, because in most of the cases when there is a phlegmon formation, they like to wait and then further go on with the further management of surgery.
Okay. You mentioned ultrasound. Is any value in this case?
Sorry, sir.
You mentioned ultrasound, didn't you? Is any
Sir,
value?
sir, maybe the patient might have landed earlier because it looks like that it is very old, not a very acute process. So there might be an ultrasound before in which there was signs of inflammation in the right iliac fossa and early signs of appendicitis with the correlating with the right iliac fossa pain. So it will add to my diagnosis of appendicitis with perforation and phlegmon formation and abscess formation.
Okay. Okay. Thank you. Thank you very much. That was a very good presentation. I'll just don't move the mouse now. I'm just gonna scroll that picture. As you mentioned, this is the appendix, and you identified the pathology quite quickly. But what happened to you in the beginning? You just got
Yes,
fixated
sir.
on this.
Yeah.
So what I would do for first 10, 15 seconds, even 20 seconds, don't just scroll through. Say, I want to look over. So sometimes you'll see a pathology, you got distracted and say, oh, maybe this is a diverticulitis, etc., etc. And actually, there's a lot of bigger problem down there. But once you pass this, because I ask you to, sometimes the examiner will not, and then you will end up in a whole situation that is not nice. But some examiner will be helpful. Most of the exams will be helpful. So just be careful. Take seconds. Doesn't take 10 seconds doing that or examine this, etc., etc. You mentioned about you define that's the appendix, that's the rupture. You want to exclude other pathologies. So what I wanted to say, if you can identify the adnexa in this, make sure they are
Yeah.
away, because PID will be a differential. Could be another perforated viscous, could be the perforated cecum rather than the appendix, but that's quite straightforward. But and you will discuss with the surgeons. And as you mentioned rightly, it's IR to see if they can drain the abscess. And it depends how sick the patient might need urgent surgery, laparotomy, and drain of the abscess collection washout. It will be difficult surgery because then the appendix is very friable. They might end up in right hemicolectomy. Might be just able to drain at this point and things settle. So involving surgeons, involvement IR, that's the right answer. And the next step of management, you just pick up the phone and call them. Excellent. I'm going to use this to move to the next case. Can you scroll
Did I
up and
pass in
down?
this case?
Yeah. Another patient with another 40 years old, presenting with acute abdominal pain. Are you ready?
40-year-old patient presenting with acute abdominal pain.
Yeah, give me 2
I'd
seconds.
say
I might do something just to help you with that. I'm just going to download it, so it'll be easier to scroll. Yeah, you can scroll now. It's fine.
Okay, sir, I see the dilated esophagus with air fluid level.
What did we just say?
Yes, sir, sorry. I'll just scroll it. Sir, actually, someone told us that not to stay quiet for long and
Yeah, you haven't spent I would say just count even 10 seconds
yes,
is absolutely fine because then I guarantee you see a lot of things more than you think it is. All right, let's go ahead. What do you think is happening? Tell me.
those are the first thing I spotted was actually the hiatal hernia with the dilated esophagus and the air fluid level.
Yeah, believe me, that's the least of his problem.
Yes, sir. And okay, sir. Then, sir, the second thing I spotted actually was again in the right iliac fossa. There was a thickening of the cecum and the ascending colon, and and sorry. And there is like pericecal and pericecal fat stranding, circumferential mural thickening, and air, most probably free air. However, I would like to see the lung window. This focus of air appears to be free, and I just want to see the ileocecal junction, which I'm not able to scroll well, but I am trying. Sorry. If
That's ileocecal junction.
that's the easy check. Okay, sorry. So, sir, and terminal ileum is the bowel also appears thickened and it is collapsed, and I have a suspicion that this might be a structure. So this is actually beyond this point. The terminal ileum is also collapsed and thickened, and there is a thickening of the bowel, and as I already mentioned, there is a high suspicion of free air.
Okay.
Okay, sir. So sir, my I would so sir, this is actually the features of inflammation involving the terminal ileum, the cecum, and the ascending colon. So it can be, sir, an inflammatory bowel disease.
Okay.
It can be tuberculosis, and but
Okay.
however, for the tuberculosis, I do not see any calcified or necrotic lymph nodes in the abdomen. The things that can favor ulcerative colitis is actually the dirty mesentery and the Coombs sign that is evident.
Okay, I will stop you here for 2 seconds, okay? I want you to go scroll up all the way up and stop here. And I want you to see is anything you notice on this slide on the small bowel. Without scrolling, just when you look at the small bowel, do you notice anything?
They're here in this one.
On the right, on the left, in the middle, overall, do you spot any differences?
So there are more of air fluid levels.
Okay,
Sorry.
okay, I'm gonna try to be more helpful. What about the bowel enhancement?
Yes, sir. Yes, sir. The bowel is not enhancing more on the right side
Okay.
as well as on the left side.
Okay, so I want you to scroll now through the bowel and see how much bowel you see enhancing and how much is not enhancing.
Yes, sir. So this part of the bowel is enhancing. This is not enhancing. Again, this is not enhancing.
Okay, look for up, go up and see more of that bowel. You see more on enhancing bowel and more enhancing bowel. So some bowel is not enhancing. What does that make you think of?
Sir, ischemic colitis.
Colitis?
Ischemic. No, sir.
Take a minute.
Sir,
Take
I
a
can.
second.
Sir, I see the thrombus in the superior mesentery.
Okay. Okay, so you see
Yes,
the
so
thrombus in
basically,
SM.
it is yes,
Okay.
sir. Thrombosed superior mesenteric vessels.
Okay, let's
Veins, sir.
look at the scan again now in a different eye.
Yes.
So what do you see in the right iliac fossa? What is happening? So there is SMA thrombus, there's differential enhancement of the bowel, but there is also something happening on the right side, isn't it? What that could be
Sir,
within
is
the
there
same
any
pathology.
fistulous formation between the small and the large bowel?
No, no. Within the same pathology. Okay, moving on for the sake of time. This is bowel is infarcted because of the ischemia. So you've got SMA thrombus. We're gonna work it through together. Okay, I'm gonna take scroll now.
Yes, sir. Yes, sir.
So what you've seen here, because you just again trying to fix a certain common thing in the pathology, you lost the eyesight. But once you stop here, you see, okay, hold on, that bowel is enhancing normally, that bowel is not. There's quite a big differential between this bowel lumen with folds in it and what happening is, and then you start thinking, okay, bowel ischemia. So I'm going to look for portovenous gas. I'm going to look for any thrombus within portal vein, and then the vessels. So the main thing here, small bowel is affecting the SMA. So SMA occlusion is very important diagnosis and also a very common case in the exam. And that will make sense because it's obstructing that side and the is affecting the distal ileal lobes and affecting the cecum. And what is happening here is a lot of fat is stranding and looks like the bowel is not healthy, lost its contact. It might be a small air bowel outside, as you mentioned. I think there's a bit of gas molecule crossing across, and then that fat stranding keeping with bowel infarct. So this is part of the bowel has infarcted or has been dead. I mean, most of the other bowels is dead too. Gonna show it in coronal, which could have made your life more also easier. Don't forget that in the exam you can window ask for different projection, but you can see here beautifully the difference between this bowel and this bowel. And then you can see here also the SMA. You see here SMA thrombus, but because it's partial occlusion, there's a couple of branches that was survived, the other ones didn't. So the final diagnosis is SMA occlusion with small bowel ischemia and also distal ileum and probably cecal infarction. Okay, any questions?
So, thank you.
Excellent. I think we've been a little bit over half an hour. Is that right? Do we have Candy too, or are you happy to see another case meanwhile?
Sir, I'm happy. If,
Okay,
no
fine.
problem.
Feeling brave. Okay, let's look at this one.
Yes,
This
I
is
want to learn.
yeah, of course. Yeah, we're all learning and loving each other. Okay, this is a kid actually who is 15 years old. I think it's even less than that. Coming with abdominal pain. So, and has been going
15
for,
years old. It's
yeah,
a 50 of 15 years old.
515. Okay,
Yes.
a kid basically coming with abdominal pain, and has been ongoing for the last week, but has been sick and more ill in the last couple of days. They examined him, the x-ray was not very conclusive. They decided to do a CT abdomen for the patient. So I want you to scroll through this and tell me what you see.
Extra CT axial slices of a 15-year-old child having abdominal pain, and so first and foremost abnormality that I see is actually the air in the uh, biliary tract. It is quite striking.
Mm.
So
Let me scroll, give me 2 seconds. Let me
yes, sir.
scroll.
Sorry, sir. I'm not able to scroll very good.
No, no, it's okay.
Sir, there is a
Yeah, what do you see? What do you think is happening?
say, can I stop here, sir, in the middle of,
Yeah,
sir,
here.
if
Oh,
this,
here.
yeah,
What do you see here?
sir, there is appears to be a stricture formation or narrowing in the bowel wall lumen with the mural enhancement
Yeah.
in this area,
Okay.
with associated with this air, so free air that appears to be. However, I would like to confirm this with on the lung window about this free air.
Okay.
Like there is a lot of free air, I believe. So there is high suspicion of any perforated viscous, and there is mucosal enhancement and irregularity and narrowing at this level.
Okay.
The enhancement pattern of the bowel appears like okay, but I cannot see any thrombus in any other visualized vessels.
Okay.
There is no free fluid. No, there is free fluid in the pelvis.
Okay.
And apart from this, it's most probably an axial cyst.
Okay.
So, sir, to summarize my finding, there is free air, there's air in the biliary tree, as well as there is
Let me scroll.
evidence of,
Yeah, let me scroll for you. Just I
yes,
will
sir.
keep on window, just to help you.
Sir, can I see the
Do you think?
coronal as well? Sorry, yeah, coronal
I don't think there's any free air. This is all air within the bowel. So
within the bone.
yeah,
Okay. So,
um,
can I have a look at the coronal, which
if
is,
I will tell you a chronal, but if I spot here, what do you see the pathology here? I just want to show this case to everyone, and then we can go move on to more. So what do you see here? Is anything that catch your eye?
sir, the air here on the, just in the, adjacent to this air, sir.
Hmm.
This looks abnormal, so this air.
Okay. Yes. So
And
look,
there is crowding of vessels in the mesentery, and
you see this
yeah, there
appearing?
is a whirl sign in the mesentery with crowding of the vessels,
What
spiraling of the vessel.
what do you think
No,
are these? What do you think are these? You know, these things here.
these are small collections.
What could be else? What else? You see these things here? Okay.
So these could be diverticuli,
No,
multiple
no.
with no.
You say there's collection, but where the collection? With fluid where? It's fluid within,
So necrotic lymph nodes.
yes. And that will tell you what if you see necrotic lymph node, what are you thinking in a young kid?
Then first and primary thing in the child will be tuberculosis.
Excellent. So this is a case of TB with ileal structure, as I said, is collapsed, some of this bowel. Actually, I had another scan, which didn't sound like uploaded successfully, but anyway, where there was imminent obstruction and bowel obstruction. That was an earlier scan before for him. And there's multiple necrotic lymph nodes. So this is an ileocecal TB, and there's a bit of thickening of the terminal ileum, not very obvious in this CT. But as you mentioned, there's a bit of dilated, there's a bit of stricturing, and there's necrotic lymph node. And when you see necrotic lymph node in a little kid, you think about TB. Yeah.
It's a quite difficult case.
Yeah, you need to think again in the abdomen, but also a little bit in the retroperitoneal, because this is just a whole different thing that can help you. Especially in big beads in general, there's only few diagnoses that comes on the CT. All right, excellent. Are we having candidate 2 or are we keeping going? Is candidate 2 ready? I think we've got about 40.
Yes, sir. Good afternoon.
Good afternoon. Thanks for dialing in. I'm gonna, I think you have to give away control for me. Thank you. And I'm gonna start with a couple of easy cases just to warm up with you, and then we'll look at some interesting cases, okay? This is a patient who coming with abdominal pain again, has been ongoing on and off for the last week and shows raised inflammatory markers. Thank you.
Okay. This is CT abdomen. So just I will start from the one side, if
Yeah.
you're okay with that. These are plain CT abdomen axial section images
Yeah.
in an adult patient, in which I can appreciate that there are motile lucencies seen in the right iliac fossa.
No, just score for a few seconds and tell me if you see where's the pathology. Just go all the way down. My advice in general, just one general scroll and then start talking of important negatives if you can't see an obvious pathology. Sorry about
Okay.
these lines. I'm not sure why it's doing this.
It's okay, sir. Sorry, I didn't listen to the history.
Just abdominal pain.
Okay.
Mostly actually is in, I can tell you, it's a left-sided pain.
I can appreciate that there is a narrowing and in the region of sigmoid colon. I can appreciate that there is a fat density area seen in the left iliac fossa with internal hyperdensity. Surrounding area is showing fatty infiltration, fat standing adjacent to it.
Okay, just focus on that area. There's nothing else in the abdomen. Just tell me a little bit
Okay.
more about this and what's your differential diagnosis?
Sir, okay. My topmost differential diagnosis based on this lesion is that it is twisting of the epiploic appendicitis, epiploic appendage leading to epiploic appendicitis. The central hyperdensity within it is the likely twisted vessel, which is the root cause of the pathology. Mostly these cases are managed conservatively, and there is no association of pneumoperitoneum or any significant worrisome features. So I would convey the findings, and mostly there are symptom-based treatment. So
What's
this
your
is
differential diagnosis in such a case?
my differential diagnosis is a mental infarction, but usually that is in the right side, and
Okay.
is not that closely associated to the bowel, and moreover, it doesn't have central hyperdensity within it.
What other differential? Important differential?
Important differential, sir, a mental infarct or any ischemia.
Okay. What else?
So should I scroll more?
Yeah, you can. Feel free. Well, I
Sir,
mean,
can I
there's
see the
pathology, but in that area,
okay, sir, can I see the coronal?
sure. In, don't think it's add any more information. But I'll just while this is loading, tell me what your thoughts.
What are my?
What your thoughts are, what you're thinking about. Why do you need the coronal in this case?
Just to see its a close relation with the wall of the colon, to make sure that it is in close approximation, which I'm quite sure, but just to be more sure.
Okay. It is close to the descending colon, if that's what you want to say. But so what could be a differential? This is more of a discussion rather than imaging. So you're right, the diagnosis is epiploic appendicitis, but what else important differential that the surgeon might ask you about?
If there is central hyperdensity, it could be with in a lab coli patient, it could be granuloma associated with it.
Okay.
Or
Okay, I'm going to stop you here. So sometimes that happens in the exam. The examiner will have a certain thing in their minds they want you to say. Is an easy case, is it bibloic, and is very straightforward. But the important differential here is perforated diverticular disease, because that's the commonest in Western culture in general, to see perforated diverticulum. So all the answers say, I don't think it's diverticular because there's no diverticular disease in the colon. This is likely also, I can't see any diverticuli in the colon, so unlikely to be diverticular disease. As you mentioned, it's a fat density sitting next to the colon. I'm sure it is epiploic appendicitis. But sometimes that happens in the exam. You get an exam and say, what else, what else, what else? And they want just to hear a certain answer. So sometimes it's easier than you think. And once you hit thinking, oh, is there a smart or anything like that, it actually can be really more simple. Okay?
okay.
So just keep it simple sometimes. So right-sided, fat stranding, as you mentioned, anyway, in the system you got free air, free fluid, and fat. That's the important thing that tells you what the pathology. If you can't find that, look at the lumens, which is bowel and kidneys, and then you look for visceral problems. Yeah, so that's just your system. You managed to spot it directly. But as I said, the first screen from the top to bottom, you can keep silent. I don't think the examiner is expecting you. Rather than saying something that can drag the discussion in a whole different direction or distract you from the main pathology. So the first scroll, just have a look, have a breathe, and then have your approach. When you go up, say, oh, I can't see free air. I would like to check with the window. I can't see any free fluid, but there is fat stranding. Probably that's the site of the pathology, and then interrogate more. This is very important because that's the technique that helps you get on with the cases. I'm going to show you now another case. This is patient presenting with in their 70s, presenting with constipation. I'm going to start from the top, and severe constipation and abdominal pain, a bit of tenesmus too. And it's been ongoing for a few days, but the pain is very, very bad in the lower abdomen. Feel free to ask any more questions or scroll through and tell me what you see.
Okay, these are contrast enhanced axial CT image in which I can appreciate. Sir, I will take a moment to scroll.
Yes, thank you.
So these are contrast enhanced CT abdomen images in portal venous phase in which I can appreciate that there is a circumferential thickening in the rectosigmoid region with the surrounding air densities in its periphery. I believe it is within the walls of the colon. Next, there are multiple. There is a calcific foci. There is hip replacement. Multiple bowel loops are seen, but their enhancement is normal. There's some fecal loading on the right side. I'm looking, sir, I will look once again in the locoregional mesorectal fat for any lymphadenopathy. This area is enhancing as well. There are some fat standing on the left side. It is not reaching the pelvic walls.
Well, I can't hear you clearly. So so I don't know why. It's a bit muffled. I can hear your voice, but I can't hear what you're saying. So try to make it more clear. Okay, so what did you say? There's enhancing, the wall is enhancing, and there's a bit of air there. Okay.
Yeah, there is mural air. The walls are enhancing. It is a circumferential mass with some, it is protruding into the lumen as well, showing enhancement. There is some mesorectal fat standing. I cannot appreciate in lymphadenopathy in the regional area.
Okay.
I'm trying to go. Sir, can you hear me now?
Yes, yes, that's more clear. Thank you. So okay, focus on the pelvis. There's nothing else in the abdomen, and tell me what's your differential, what your thinking process.
Sir, I'm thinking in an old age patient with there is a hiatal hernia as well. I'm thinking of a straight away malignancy. Patient needs to have a sigmoidoscopy with biopsy. And also, I would like to see the parenchymal, lung window as well to see any signs of pneumoperitoneum
Any
because
other?
there was.
There's no pneumoperitoneum. There's no free air. There's no free fluid. Can you just go back to that lesion again? And what would be your differential?
So there are some hypotensive hepatic region, hypodensities in the liver as well, which I believe are cysts, but I would advise a close follow-up for that region as well.
Okay. Usually, if you think that there is a liver lesions within cancer, you have to ask for liver MRI or if it looks suspicious anyway. But I think this is long lasting. It's not a part of the pathology. So, but that's just for general information. Anything else can help you understand, help you with this differential? So you said it's a mural air, is it? Is it a mural air? Look at the air and tell me where is the air?
Sir, it is.
And what do you see in the middle?
It is. Yeah, it is within the. Serosa is intact. It seems in the muscular compartment.
What do you mean by muscular compartment? And
Sir,
don't look for anything else. There's nothing else.
sorry, sir. I'm not doing it. It is going on itself.
Yeah, that's okay. That's fine.
I will try to be focused here more.
Okay. Anything can help you. I can do to help you.
Yeah, sir. If you can provide me coronal and
Excellent. Okay.
any other plane.
No, the coronal will give it away anyway. So always ask for recon sometimes. I'm going to show you that. What do you think?
Sir, it looks like interception.
Okay. What is intersuscepting into what?
It is.
You can scroll yourself too, right?
Okay.
Did we lose it? No, stop. Okay. From the other direction.
Okay. Sir, looks like a small bowel loop.
Is it?
Yeah, this one looks like a small bowel loop. And sir, can I see in any other plane, sagittal as well?
I'm just gonna move this up so it'll help and zoom a bit for everyone. So give me 2 seconds. Don't scroll. Give me 2 seconds. And then drag that. Okay. If you follow that up, you follow that lumen, it gives you up here, isn't it? So that's not a small bowel.
It is a small bowel loop. I
Don't
think
give up.
both
You
of
can get
them.
it. You can get it. It's easier. It's not a small bowel loop. I think you can still get it. Come on.
It is colic interception with the.
Yeah.
So but I want to see it once again on sagittal.
Well, it'll take more long time. I think the coroner will give you the information. We can give you such. We can try for everyone's sake also because it's a nice case. Did that help?
So the mass still appears to be in the rectosigmoid region.
Yes,
And
the sigmoid protruding out. So it's here. So that's I'm gonna cut this short for the sake of time. This is a sigmoid rectal intussusception. So the sigmoid acute, and the patient presents acute. I'll probably put it in the axial, and again in the coronal would be easier. And you can see that the sigmoid is just going through that. That is a sigmoid mesentery that you can see here, and that area you've seen in the axial was actually that's the rectal wall. So that's a rectal wall. That's a rectal wall. And then that's intussusception where the sigmoid wall is, and then that's the bowel going down. And if we look at it in the axial, and that's what you need to say in the exam, especially on old patient, is there is a lesion there. And as there is a, you see here, that's the lesion here, quite thickening here. And that's actually turned out to be a sigmoid polyp, large sigmoid polyp, where it's just gone all the way out of the anal canals, causing acute sigmoid rectal intussusception. But the bowel upstream is not obstructed, as you said, there is a fecal loading and not obstructed. But again, this is just a rare case. It can, but you can see interception elsewhere. But this is a case how we what intercepting what, and in an old patient, you need to say we need to exclude a polyp or a lesion in this case. Yeah.
Need to exclude what?
So any lesions. So in this case, it was a sigmoid polyp because that would be the leading point. In all people, there's usually a tumor leading to this, either lipoma, either malignant tumor, or a polyp that can lead to this. And then you look at that, there's a lesion there. I want to look sure if there's any lymph node, and then you look at the liver, as he said. There's any lesions, hyperdense lesions, looks like cysts or hemangiomas, but again, you might ask for MRI or ultrasound to confirm. But that's it really. So this is acute sigmoid rectal intussusception. You've done really well with it, by the way. You split the pathology, you analyze it right, you ask for a little bit slower, but because you've never seen it before. But sometimes if you can solve it in one plane, just ask for a different plane. And when you see something, interrogate it a little bit more. And the examiner will try to help you. Okay, is that air? But you can see there's a wall around it, and there's a wall around it, and then that's a fat density in the middle. So that's like a target sign intussusception. Yeah.
Okay.
Any question? Are you happy with that?
Yes, sir. I'm happy with that.
Okay. These don't sound though. But anyway, let's go on the next case.
And now I'm.
The next one is the less torturing, hopefully, for you. Okay. There's a patient who presented with again abdominal pain and has been acutely in the last 24 hours. We thought it might be a perforation because it's a very tender abdomen, so we give an oral contrast. If you want to scroll, tell me what.
Okay. This is contrast enhanced CT abdomen with oral contrast as well. In an adult, I will take a moment to scroll from top to bottom just to have a review. Okay, so I will again move to the top slides. In this, I can appreciate that the oral contrast is having a leaking and it is collecting anteriorly along the liver surface. There is extensive mesenteric haziness. Vessels look normal, and thus I'm trying to look for the site of leak, and I believe that it is in the duodenum, and it is tracking along the anterior wall, lateral wall of the duodenum, and is collecting anteriorly. It could be due to duodenal ulcer, or a patient could be on long term some medications for joints disease or something, which have led to it. I can also appreciate a no, this is not calcification. This is contrast in the duodenal region.
Okay.
The contrast is surrounding the duodenal jejunal loops. There's a drain in place, extensive anterior abdominal wall edema.
He had surgery a few days ago for a different reason. Okay.
Sir, what? Sorry.
Yeah. It's a different history. Sorry, this patient had a different surgery for a different reason. But can you go back again to that side?
To so
So
there is a mural.
this is it. There's nothing else in there. Okay, so you got oral contrast that is coming out from the duodenum. It's a duodenal perforation. You just need to wrap up the case now. Yeah, and see the.
Okay, so this is quite a severe emergency case and it needs to be treated urgently. And I will communicate the findings because patient might get into shock or something. So I will immediately contact the on-call surgical team for immediate, I think laparotomy should be the next step of management.
Yeah, this is a nice, interesting case. You can get duodenal perforation. Sometimes you can't see it in a normal. What you're gonna have to understand what you recommend. We can do oral contrast and repeat, or we can track the air where it goes. But this is a nice case where we can see the defect on the duodenal wall and it's just leaking contrast outside into the abdomen. The patient had a previous surgery for a different reasons. I can't remember in particular, but the ones weeks were left the drain in. And anyway, they presented acutely with acute abdominal pain. But that's a case of duodenal perforation, so that's nice. So I think that sometimes it's just straightforward. That's what we see. We need to inform them what it will be the treatment, probably urgent surgical exploration. Sometimes you can treat conservatively, but you try to exclude other signs of perforation too. But that's quite a straightforward one. Okay, I think we're doing still well for time. And this is another young female patient in her 20s coming with acute abdominal pain. Her urine pregnancy test was negative, and the team was worried about whether there is appendicitis, there is any other pathology, gynae pathology. Anyway, she was acutely unwell, so we decided to do a CT.
Okay, and this is a contrast enhanced CT abdomen of a 20 years old female who presented with acute abdominal pain in the portal venous phase. And I will take a moment to scroll. This is arterial phase actually.
Yeah, not really a good portal venous, isn't it? But yeah, she's young.
So in this imaging, I can appreciate that there is a gravid uterus and there is enhancement, quite significant enhancement of its wall, and there is there is no internal gestational sac is seen. I cannot appreciate any free fluid. So can I see any other plane? It looks like uterus. The bowel is normal, and I will.
What plane you wanted in?
Sorry.
What plane? You said you want a different plane.
I will, sir. I will first go with sagittal if you are happy with that.
I'm happy with that. You ask what you like to ask, so all fine. It's coming. All right.
So this is the sagittal CT of the same patient in which there is a fluid level within.
Okay.
There is contrast within. So I will.
Let me scroll for you. Let me scroll for you. I think. Oh yeah, you
Okay.
can. Okay. Well, I can do it for you. It's fine.
Okay, sir. There is definitely contrast within it, and there is a fetal pole as well. Uterus looks gravid.
Okay.
And I'm thinking of any, yeah, it could be retroplacental bleed.
It's pregnancy, yeah? It's intrauterine pregnancy.
Sorry?
It's intrauterine pregnancy, yeah?
Intra-uterine. So can I see once more for sagittal, just to make sure the any adnexal status, because it looks definitely intrauterine, but there's sometimes a pseudo-gestational sac within the uterus once there is ectopic, and the fluid level within.
This is intrauterine pregnancy. How do you explain the negative urinary test?
Because it could be very early, or it could be fetal demise, or it could be some chromosomal abnormality.
Okay. Well, it's something that can happen. So you can get false negative because of very high concentration of HCG in the urine. That the strips they do for the test is not accurate, and it gives you false negative. So this is intrauterine pregnancy. All you need to say, I can see both sister is not ectopic, and there's no other acute pathology. But this is a rare case where we scanned a pregnant lady. So that's why it's important. It happens between 8 and 12 weeks. It's very common. So for that age group, for that time of that, so you have to check blood. So blood HCG is more accurate than the urinary test. So yeah, this is a rare case where we did a CT for a pregnant lady.
So why is there intense enhancement along the anterior wall? Is it some retroplacental
The placenta start forming, and that's the fetal ball here. So that's the fetus here, and that's the placenta.
Okay.
But I'm not very expert in the gynae, so I wouldn't take it any further than this. That's okay.
Okay.
So what's the diagnosis for this case? Sorry.
So this is intrauterine pregnancy. That's it. There's nothing else happening with this patient. Okay, I'm gonna move on to another case, if that's okay.
Yes, sir.
Any question? We're still with candidate 2, I think, and I'm gonna. We can still with gynae. No, let's give you something a bit different. Okay. This is a female patient, young, in her 20s, coming with vomiting and not feeling well. And you can hold for me up and down. Just again, just takes time to load.
This is CT abdomen, contrast enhanced exit section of female with vomiting. I will take a moment to just go through the images once. In this study, I can appreciate that there is quite significant dilatation of the bowel lobes. Starting from the stomach, I can appreciate that there is motor lucensis within the stomach wall, duodenum, and it is extending up till quite lower down the abdomen, and the rest of the bowel lobes are showing normal enhancement, but there is significant dilatation. I can also appreciate some free air foci along the just posterior to the right.
Just to tell you a little bit more about the story. So this patient was unwell. They took her to theatre. They couldn't find anything, and they got her out. And they thought it might be appendix, but everything was negative. So she was still at that, and she was still unwell. They decided to do the CT. So that free area is with recent it isn't in laparoscopy. To just put a camera in to see what's happened. But so keep scrolling down. What do you think? Where's the transition zone? Can you see transition zone? What do you think in process? What do you think it could be? If you want to put any window, I can zoom in a little bit for you also, so that helps.
Yes, sir, if you can.
Okay, just give me 2 seconds. So let's zoom in. And then I'm going to span, look at here, and then continue. Hopefully that will cover it. Yeah. If you want to put it in a different lane, you can scroll now. You can take over and scroll.
Sir, I believe this is all small bowel, and I'm trying to look for the transition zone.
Okay.
And it looks in the right iliac fossa.
Okay. Where can you
So
show
can
me?
I see?
Where can you show me
Okay,
where the transition zone is?
this area.
Okay, so that's a collapsed bowel. Where is the first bit that is dilated?
Let me follow it a bit.
Do you see that?
This, sir, can I see coronal plane?
Okay,
It
yeah.
looks on the right side.
Okay, let me get the coronal plane for you. Stop moving. 2 seconds. Yeah, go for
Yeah. These are the coronal planes of the same
it. Yeah.
patient. I'm looking for any hernial orifices. Cecum is collapsed, and it is a little more clear on these images.
Okay.
The terminal ileum is showing. Terminal ileum is also not dilated.
Mhm.
It is. I'm trying to follow gut a little bit. There's a small bowel fecal sign as well, so the bowel has been dilated for quite. Us. It's
Okay.
not very cute, I believe.
What do you think that appearance in the small bowel and the stomach, is that related? Could be related? What
So
if
the
that?
stomach appearance looked, at a glance, it looked like bizarre, but
Okay.
bizarre usually doesn't go further, and it doesn't lead to an intestinal obstruction of this level. So I'm looking for the hernial orifices as well. There is also no any obturator, inguinal, femoral hernia.
Okay.
Next possibility could be tuberculosis. And tuberculosis, the bowel loops are usually clumped together, and they don't look clumped. And moreover, there is no significant enhancement of the peritoneal reflection. There's somewhat ascites is noted, free fluid.
Okay.
Tuberculosis could be option, but the stomach picture is that of bizarre.
Okay. That's,
Mm,
thank you. You've done really well with that. So what are you going to be next case for? What are you going to tell the surgeons? Or I assume you're going to call the surgeons, yeah? Or they are calling you anyway.
yeah. Sir, I am going to tell that mm, the free fluid needs to be aspirated, and there should be some. They should correlate with a psychiatric history if there is history of any psychiatric illness
There is
or
psychiatric
any.
history, yeah.
There is,
There is, yes.
then it is a bizarre which has traveled on, or there could be a element of perforation or part of it.
That's what it is, yes. So there has been
Yes, I believe that a part of the bunch of the hair has lodged into this part of the bowel.
yeah, and that's where the transition zone, you can see it collapsed after and distended before. So that's the key thing. So this is a rare case again of Bezoar, of which was a lot full of the stomach, full of hair. They managed to get, I think, over 2 kilograms of hair from here. Anyway, so got all that hair, and then the part of that traveled in the small bowel and somehow got stuck in this bit. Where you can see proximally is more distended bowel and distally is more collapsed in that area. You can see it more clearly in axial, but that's a case of Biswa. All you need to tell, sometimes it's difficult, and in the exam you can't be certain, but you can suggest things. But this high grade small bowel obstructions, we need to get lactate. There's no signs of ischemia. There's no, I mean, there is air, as you mentioned, because there was a laparoscopy. They couldn't see anything. They saw it's a different pathology, and they couldn't identify that. But that's a small bowel obstruction. They need to do something about it. Actually, they operated in it and opened it up, and it turns out to be bizarre because that's where the transition zone is. And the bowel collapsed, and then they opened the small bowel and they found the bizarre. So sometimes in the exam, you're going to rare, you don't, but be systematic, exclude it. You don't need to get the definite diagnosis, but it's nice to think a little bit outside the box. And as much as you save, you get the mark. So for example, your performance in this case, I will give you 6.5, even 7, easy. So you usually better than you think you are. is just be systematic and not distracted, and don't take back. You know, sometimes you get back if it's wrong. That's absolutely fine, and if you're aware of the examiner trying to help you, but just be that presentation and open up for a little bit of lateral thinking. Any question about this case from you?
No, sir, thank you.
Oh, that's
Was good.
candidate 2. Are you? I don't know if you have candidate 3, and if not, you can keep going if you like. I'm gonna get.
Yes, sir. I'm happy to keep going.
Um, we don't have a candidate 3. Just give me 2 seconds. I need to load up and. Um, I'm sorry, excuse me, 2 seconds. Yeah, let's say here. Didn't go on to do it. I'm sorry to keep you waiting. Just a second, it's just loading up. Can you see something or not yet?
Yes, sir. I can see an image.
So this is patient presented with acute abdominal pain, and we did different phases of the study. There's our triple phase study. So we've got non-enhanced, we've got AI, venous and arterial. You tell me what phase of contrast you want. We have a CT tab. So thorax, abdomen, and pelvis. He presented with severe abdominal pain, epigastric pain. They query a lot of things, so we did that triple phase. Tell me what phase you like, and you can start.
Sir, plain. Sir, I would like to see plain first.
The what, sorry?
No, arterial phase.
Arterial phase. So that's the arterial phase. And you can scroll.
So this is the contrast enhanced. Sir, can I start?
Yeah, please do.
So this is the contrast enhanced CT abdomen in the arterial phase, in which I can appreciate bilateral pleural effusion. There is bilateral visuality lactasis. There is pericardial effusion as well. The heart size is normal. I can appreciate a flap within the aortic lumen, which is on the right side, and it is. So wait a second. Sorry. And it is extending along along the celiac artery, along the renal perfusion is normal, and I'm trying to go. It is also extending along the its bifurcation, and is ending up at the level of the left iliac vessels. And even both of the iliac vessels are showing significant dilatation as well. So it is a component of aneurysm as well. I'm next trying to see any surrounding soft tissue range, or any contrast extravasation into bowel. The kidneys appear normally, and no, I can appreciate that there is a less enhancing area in the left kidney, which could be phasal as well. Sir, next I would like to see any other plane as well. So based on these findings, it is a dissection extending all the way along from the thoracic aorta down till the both iliac vessels. And what I'm concerned about is I would like to see the bowel enhancement and its extension into the vessels.
What do you want to do now?
Coronal phase.
Do you want a different phase, or are you happy with the arterial?
Sir, I would like to see venous phase as well.
So portovenous, yeah, not venous, portovenous, yeah. So that's your portovenous phase. Please scroll and tell me what you see.
Yeah, I will.
And then I'm going to ask you a question.
Patient has been intubated ETT, NG2, both are in place. There is So there's decreased enhancement in the left kidney posterior part. Posterior part. I uh, I I had a suspicion on the but I cannot see any the
Okay.
there the dissection flap is definitely leading to some hampering in the celiac trunk. So the celiac trunk is affected, or it is also possible that I'm now looking for which is the true lumen and which is the false lumen.
Yes, that's what I wanted to
So
ask you. So which one is
mm,
the true, which one is the false?
I believe that the smaller one is the true lumen because there is lack of enhancement on the left kidney.
So which one is the false again?
So let me confirm once again.
Sure. So how do you confirm?
Sir, I will see the coronal plane.
No, you follow that, you follow this. You're still an axial. What I'm going to do, I'm going to help you and give you both of them next to each other. But what you need is to follow the flap. So just follow the flap and tell me which one is the true and which one is the false.
Okay.
Go all the way up.
So
Go all the way up.
there are some internal densities and shadows in the left one.
Okay, let's finish that. Which one is true and false first? So where is the true? Which one is the lumen? Show me the true and false lumen. This is important in the exam to be more consistent, yeah? So don't go into tangents about something else before you finish what you present. This is a Q presentation. You go on the diagnosis. What you need to know is this is important information for the team. Where's the starting point? What type of the dissection? Because that will decide the management. And then the next is which is true and false, and if there's any acute ischemic. But then I'm going to
So
ask you.
it has started after the origin of all the three major vessels, and I believe that the smaller one is the false lumen.
Okay. I might disagree with that, but I will show you 2 seconds. That's not a problem. Now I'm going to ask you something. Let's focus on the portovenous phase. Is anything else acute to tell me just about this case?
There's hyperdensity along interiorly.
Okay. What do you mean? Which hyperdensity?
It is within the this one.
Oh, what is that? Good question. Okay, you spotted that. So what is that?
So that is interior to the kidneys. That is jejunum.
So first, what is it? Is it a blood vessel? Is it a lumen? You say it's a bowel. You think that bit is a bowel? Is that what you're
I
saying?
don't have the wall of bowel.
Okay.
I'm trying to trace it a bit more. It is leading to portal vein and
Okay.
it
Where is
is
the
inferior mesenteric vein. No.
okay? Where is the portal vein?
Portal vein. So portal vein is showing cavernous transformation.
You sure? Okay. What's happening in the arterial phase?
In the arterial phase,
On this cavernous malformation, you say it's cavernous, is it?
so in the arterial phase, there is it is early visualization of these cavernous. So there is a fistulous communication.
What else could be?
It could be an artery.
Try
There
and put
could
it
be
all
vessels.
together. You've
Sir,
you're really doing very well, by the way. You're doing amazing. So you spotted a lot of things, which is good. So keep going. You can,
okay.
so that this cavernous looks arterialized. You say might be fistula.
Yeah,
It's difficult for fistula to arterialize all these vessels, isn't it? What could be differential?
so differentials could be mm, any fistulous communication or any thrombus which is leading to
Okay, what other
the
differential? And what is happening to the portal vein again? Or portal circulation? So think about it. If you can
portal vein
follow,
is not, it is replaced by a bunch of vessels in which are visualized on the arterial phase.
okay. So it's not really obstructed, isn't it? It's not there.
It is not there, yeah.
Okay, follow that vessels, which you said, you know that density on the portovenous? Yeah, follow it
Mm.
on portovenous, yeah? So I'm gonna hear that one. Just let me, and then scroll down from that and follow it down. You see that one you identify in the beginning. Follow that down all the way down.
In the portal venous phase.
Yeah, follow all the way down. Go with it. Go with it. See where is it going. Just drag that. You can drag that ball easier than scrolling the mouse. But
It is ending. It is
okay.
it is ending. I don't think it's going any further than this, and it doesn't look like definitely not gut loop. And there are surrounding multiple dilated vessels as well.
Okay.
So they are all dilated varicosities, dilated bunch of vessels,
Okay.
which are there could be some thrombus, and this is the alternate collateral route.
Okay. Any more thoughts about the dissection or that vessel? Then I'm gonna take over. I mean, you've done really well. I'll pass you for this case for sure. You've done amazing and you spotted a lot of pathologies. But I'm gonna tell you the answer now. Let me scroll
Yes, sir.
for the sake of time of everyone. So that's the dissection, and when you follow the flap up, that's the way you follow the dissection. So that's the true lumen, and that's the dissection flap. You see that? That's the opening. So that is the false flap. That's how you identify false from true. So actually, that's the true lumen, and that's the false lumen. You agree?
Yes, sir.
So the false lumen is mostly is the bigger lumen usually, but you have to track it and show it to the examiner. This is an important part of the exam. So what is happening here, and I told you why this is important, is this is called a Bernathy malformation. But basically, the portal vein is not existent, congenitally absent, and that's the IMV and the SMV. IMV is draining all the way back to the IVC. Do you see that? And it's draining into the IVC. So follow that up, that's the IVC. And that's the connection between the IMV, which is bulky, with the IVC. And then the IVC is quite enlarged and causing also right-sided, so go into the heart. And why I'm saying this is important, because if you think this is just a collateral, it's arterialized collateral. So this is collaterals coming from the hepatic artery. And lucky for this patient that, as you mentioned, he's at risk of compromising his celiac trunk, which he truly mentioned. And that's very important because that's the only blood supply for the liver. Because it doesn't have a portal vein. Even if it's obstructed, this is an important thing to know. We need to be careful because that dissection is just involving the mouth of the celiac trunk, which is giving the only blood supply that going to the liver. So lucky for this patient that actually the celiac trunk is coming from the true lumen. And as you rightly say, it's a bit iffy scan because a lot of the hand is inside of the patient, but there is some hyperperfusion of the left kidney. You can raise that up and probably need to follow that up and see what's happening with that. But this is a case of Bernathy malformation with aortic dissection. And that's why it's important to recognize the dissection flap and the blood supply to the river. Hopefully, you have any questions for me?
Sir, so it is always the smaller lumen. Mostly it is the
No,
smaller
I
lumen
mean,
which
you
is
have to follow it up. I wouldn't put a rule on this. For most of the dissection flap I've seen, 90% of what I've seen, which might be nothing, I've seen at least 15, 20 dissections in the last 4 or 5 years of my career. All of them mostly is 90% is coming the full swing of that. But don't do that. You follow it up and you see where's the true lumen. So that's the flap, that's the false, that's the true. You don't just assume, yeah?
Okay.
Just follow the flap and you should be able to see it. It is difficult, the mission of moving, we might need to do something gated or something like that to identify it, which is fine. You can do gated scan for aortic dissection. That's important to identify also is distal to the subclavian branch, so type B dissection. Okay?
Okay.
It's a difficult case, but you've done really amazingly well. And the whole point is not necessarily reaching the diagnosis, as I mentioned, is just having a thinking process, and you have it there. It's just having a little bit building of confidence of practicing more. And the exam will be the case is much more straightforward than this. This is just a rare exam to put you in a spot to help you and develop your thinking process of the unknown. Do we have, okay, thank you very much. You did really well with most of the cases. Do we have a candidate 3? Or we can
Thank
move?
you so much, sir.
Yes.
Okay,
Hello?
excellent. Give me 2 seconds. Somebody need to give away the control. Can I just take about 2 minutes comfort break and we'll come back if that's okay with everyone? Just
Yeah.
2 minutes exactly. Hello, sorry, it's my mistake. Now I'm unmuted. So candidate 3, are we? Hello,
Yes. Yeah. Hi.
are you ready?
Yeah.
Can you request control?
Yes,
Okay,
please.
go for it. I can't see a request yet.
Is it working?
I can't see requests. Maybe.
How can I request it? I didn't.
I don't know if I can give you the option for that.
Sorry, I
I
didn't.
think there's on the screen, should be. I don't know if I can give you control, but I think it's easier if you request it and I'm able.
Yeah, yes.
Yeah, excellent. That's it. Excellent. So on that screen, you can see something. Yeah. Okay, you can scroll that. So this is a patient. You can ask me if any history you like, but they're coming with abdominal pain and diarrhea, and bits also feeling sick. You can ask me any more questions if you like. That helps with your diagnosis, but I would like you to have the surgeons haven't seen them, and this is just ask for a CT abdomen. This mostly commonly happen. So tell me what you see.
Okay. So this is the contrast enhanced abdominal CT. I can see the liver is fatty, has fatty infiltration. Just scrolling down. The ascending colon appears as some mural thickening.
Yeah, you're a bit quiet, so shout out.
Sorry.
That's fine.
That I can see that transverse and ascending colon shows some circumferential mural thickening, long segment. I'm just scrolling down. So there is no free fluid. The Sigmoid appears attenuated. Sigmoid lumen. Rectum appears unremarkable.
Okay, that's good. So let's focus on that. What do you think? And is anything in the history you want to ask that help you with the diagnosis? Or do you want me
The
to
patient
scroll?
has
No,
constipation and
it's having, as I said, is they having diarrhea and feeling sick.
sorry, diarrhea. Yeah, okay. Any about the inflammatory markers, is it increased?
No,
Okay.
it's actually the other way around.
Okay. Sorry.
Okay.
I'm just trying to scroll. So
So
the first.
I'm gonna help you. I'm gonna stop here. I'm gonna help
Okay.
you to say that I'm gonna scroll. You just give me control. Don't scroll anymore.
Okay.
I'm gonna show just the coronal. As you identify, the pathology is in the right side of the colon and is thickened. What's your differential?
So first, because this is it looks as a segmental distribution, so I would like to check the vessels
Okay.
to interrogate for any
Okay.
ischemia.
So you can see which vessels you want to check.
Superior
So
mesenteric
that's a good
artery.
thought. So superior mesenteric, as you can see, is very patent, and it's fine.
Yeah, and also the vein. I think the vein is
The vein is
adequately
fine.
calcified. Yeah.
Okay. What other differential?
Can I just start to
I
scroll
told you a
again?
little bit about that when you ask about inflammatory markers. I told you this is the other way around. They're very, very low.
Very low. Okay. So there might be some neutropenia or something like this. So
Yeah.
Yeah. So first, I would think about
Let me scroll for you because it seems
oh,
like
sorry.
no, it's fine. Next case I'll let you, but you don't need to scroll anymore. You don't need
Oh,
to see
okay.
the exam.
It's
You've
just
already followed the
jumping.
pathology and we're having a bit of discussion.
Yeah.
So there's
Yeah,
no
it
need to.
jumps. Yeah.
Yeah.
So first thing, if the patient has neutropenia, I might think about fecal inflammation.
Yeah. What is
The
it
other,
called?
I'm sorry,
What is it called?
neutropenic typhlitis.
Typhlitis. Okay.
The other differential could be the if the patient is on antibiotics, extensive antibiotics, I might think about, because it's involving the ascending and transverse colon, I might think about toxic megacolon or.
Okay. Do you see any toxic megacolon?
But it's not distended, it's just a mural thickening.
Okay. We'll stop here. This is a case of typhlitis. And if you ask me a little bit more, say this is a patient who are in chemotherapy too, and they have neutropenia. That just gives away the discussion about typhlitis. Differential could be ischemia, as you mentioned, but also Crohn's disease affecting the right side of the colon, but usually that's not the right side of the distribution. Terminal ileum looks normal. And you can just say that I want to check the rest of the colon and also want to make sure there's no perforation. That's just to be systematic and wrap it up. Sometimes I put you an easy case or something easy, not necessarily complicated, just to make you gain confidence and marks as you go in the exam. So sometimes it's just straightforward as this. It's just right side inflammation. There's no free air. Or you ask me, is there free air? I would like the window. There's no water. I ask about the history. And there's typhlitis. That's it. Excellent.
Okay.
All right. I'm gonna talk about the game a little bit more. This is one of my favorite cases. So this is patient who coming again with the right upper quadrant pain and sepsis. Surgeon see them, quite tender abdomen. They ask for a CT abdomen. You can scroll now. Tell me what you see. moving a little bit towards the upper GI. I think I
So I
got
can
two more
see.
cases that I want to show everyone before the end of the session.
So the left lobe of the liver. There are multiple ring enhancing.
Yeah, so as I mentioned before, just the first 10 seconds, just scroll through.
Okay. Okay.
The examiner will tell you what to do. You say, okay, no need to scroll anywhere, just focus on the upper abdomen.
Oh, okay.
So focus on the upper abdomen now. So tell me, what do you see?
So the patient has fever and, sorry, about the clinical.
Right upper quadrant pain and fever.
And fever, okay. So what I can see here is extensive intrahepatic bilobar intrahepatic biliary dilatation, and there are multiple ring enhancing hypodense lesions, coalescent, involving the left lobe.
Okay.
There is there might be some communication with these lesions, with the biliary tree.
Okay.
However, I would like to check the bile duct and the gallbladder. So there is multiple gallbladder calculi.
I think you'll start mumbling, so start speaking clear again. So multiple calculi
Sorry.
and bile duct.
In the gallbladder, yes. Yeah.
In the gallbladder, you're saying?
Yes, yes.
Can you show me the gallbladder?
Oops. Sorry, it jumped down. This is the gallbladder. So they are in the common bile duct.
Okay. For mind crawling, you might want to use the mouse rather than or the keyboard rather than the scroll. So just use the mouse.
Okay.
The wheel on the mouse will be easy.
Yeah. I think keyboard is slower, so it's better for me.
Yeah, I'll put it on coronal just to help you.
Okay.
So the key thing for this case is just to ask for coronal, because sometimes it could be difficult to see what you want to see. While this loading up, just 2 seconds. Again, that can happen in the exam. It's fine to have a few seconds of silence. Grasp your thoughts. And just when a picture comes in, tell me what I'm gonna zoom in to help you. And then start scrolling and tell me what you see. See.
I can see the portal. There's portal vein thrombosis, I think.
Excellent. Well, that's a good spot. That's a blast. Can you put it all together? You mostly mention all the pathologies now.
So there is choledocholisthesis with enhancing CBD wall, which is suggestive of cholangitis, acute cholangitis, complicated by intrahepatic biliary dilatation and multiple hepatic abscesses, as well as portal vein thrombosis.
Excellent. That's it.
So I will.
What do you want to do?
Yeah, I will alert the referring clinician and refer to the upper GI team to start treatment, which will
Treatment you're gonna start?
Start the patient on antibiotics, fluid replacement, until the patient will settle down. Then they can do the, I think, retrieve the calculi through ERCP or something like this.
Something like this, like what?
I mean, ERCP usually.
Okay. I think you just need to, you have the knowledge, you just need to work on the presentation a little bit more. How do you put systematic and then be fluent? This is called prompting, and it's not good for the exam. I'm trying to get things out of you rather than you offering me things. So anything within the liver, we need to look at two things: biliary tree and portal vein. Just full stop, okay? You've seen something in the liver, you need to assess that. If I didn't put it in the corona, you might not have thought about the portal circulation. So you just need to be proactive and have a, again, systematic approach. As you mentioned, there's something hyperdense. Is it in the gallbladder? No, it's in the CBD. So this is a case of cholangitis with multiple stones in the common bile duct. Surprisingly, the gallbladder don't have any stones in them. You might have a B stricture down the CBD, so we need to get more information. And there is portovenous thrombus, as you mentioned, but also quite significant intrahepatic biliary dilatation. This could be abscesses. For all this, there is a malignant lesion underneath this. We don't know. So you might need to further image this and follow up. And then you can request, you start with antibiotic to manage the sepsis. You need to think about the portal vein too. And then you need to think about how we're going to get the stones out and how they're going to drain the abscess if needed. So, and take samples from it. So you need IR to be involved. And as you said, upper GI and the gastroenterology need to work together on this case. I need to management plan regarding the thrombus together with the ARCB. But this is how fluent, you should be just thinking, you got the information, you got the knowledge, but you showing out, you asking me rather than telling me, that kind of thing that is very important before the exam to sort out, because it will affect your scoring in the exam. Okay, I'm going to show you an interesting case.